now we are going to have the next 10 minutes where I invite the committee to ask the panelists questions, and we'll just move through that. And committee members, if you'll just signal me, we'll go forward. And certainly it's been, while you're collecting your thoughts, I'll just reflect on a few of mine. To hear about artificial intelligence, to hear about our call to action about structural racism and not allowing technology to eliminate or create more barriers, extraordinary. To hear about how the application of CHAMP and other things are emerging. It really calls us all to think about how all levels of nursing will be implicated in the rapidly accelerating field of all this IT and artificial intelligence. So committee members, do I see hands? Yes.
Thank you, panelists, Dr. Coy and Ms. Baird and Ms. McCarthy. Very different presentations, but obviously very complimentary and thought-provoking. It did reinforce my anxiety and angst about technology in general. On one hand, I think in my own life it's been very facilitatory. At the same time, it's also been something I almost fear and dread in terms of just how it continues to erode some of the issues with regards to being a human being and privacy. So I want to dig a little bit deeper into maybe if you could think about this as an example. So most recently in San Francisco, we actually passed an ordinance to say that digital facial recognition would be illegal as far as governmental procedures within the city and county of San Francisco. And I think there was an example, for example, that someone raised with regards to a woman who did not speak English, who was unable to check in because she couldn't really read the messages that she had to just recognize that she had an appointment. It would seem to me in that kind of situation that maybe facial recognition would help to facilitate identity and be able to facilitate people going through the process of getting access to quality health care. On the other hand, a lot of the criticism is around racial profiling and implications for implicit bias. It's hard to think about implicit bias relative to artificial intelligence, but I would love you to kind of explore these issues as an example of how the digital revolution really interfaces with complexities with regards to how we really look at facilitating access, addressing racial inequity, and thinking about the possibilities of using technology, which incidentally is only an invention of humans. So can you just maybe use that as an example and provide us with some thoughts about how this would be an example or a paradigm of how we look at this interface?
I see Molly kind of leaning forward.
Yeah, so great question. I think that as a technology company, we have quite a few examples of failures where we've actually come out with technology design that hasn't been inclusive. For example, we came out with a controller that was designed by men and tested on individuals 18 to 54. And it turns out that it did not recognize women or children. And so one of the issues that we're faced with as a large organization is, to your point, technology is designed by humans. So who is in that design process? It has to be diverse and inclusive. And so it really starts with who we're involving in all of these processes. Really beyond thinking about the end product or the end technology. And so that really means that, you know, we do need more women, more just a more diverse group who's involved in this process from the beginning. Another example is a chatbot that we had a few years ago. I don't know if anyone heard about this, but essentially it was powered by AI and it was learning as it went along, and it started working with racial remarks that were, you know, very disparaging, and it started copying them and mimicking them and putting it back out into the market. So again, another example of just failure in our systems. And so it's a great question. I don't necessarily have an answer, but I know that as a company, we feel very responsible and pushing towards developing those standards along with different organizations. Did that answer?
Yeah, I think we're going to move on to our next question. Go ahead.
Hi, good morning. Vicki Tiazzi, thank you so much for your presentations this morning. As a nurse informaticist, I am very excited about the prospect of technology transforming nursing practice. So as an educator and as vendors that are working with various organizations, could you comment on the level of preparedness that you're seeing in nurses and their interest in technology, and perhaps examples where you see nurses being very prepared and very engaged with the technology?
Dr. Coy, do you want to begin, and then Dr. Kenya?
I would just give a couple of examples in Seattle, in this area. There's a health system called Providence, where the nurses have taken the lead in adopting some technologies in their rounding process that has cut the documentation time enormously so that they're able to spend more time face-to-face with their patients. And the nurses led that and also co-developed some of the future improvements in the technology. So I think if you sort of scratch the surface, you actually find a real willingness, just because, like everybody else, technology permeates our life. And so if you can present something that actually is solving a problem, a real problem for people, then I think nurses are potentially really interested in it. The other thing is that nurses were very involved in developing a Circle, which was a new app for pregnant moms, which tremendously improved their appropriate visits, reduced the C-section rate, really had a tremendous impact. So I just want to add as a proviso that I certainly think all technology has the potential of harm and good. I live in San Francisco, and I agree with your comments about facial recognition, but I think it's really important not to sort of say technology, but instead just look at it, and it all has horrible potential for inbuilt bias that's really very important to address.
I was just going to echo what Dr. Coy said. You know, when we think about technology, it's just a tool, it's a vehicle, it's us. We are the ones that can make it do things that it wasn't intended to be used for. We could look at social media platforms, we could look at the election, we could look at hacking. Again, it's a vehicle, but sometimes we use it in the wrong way.
Can I just say one thing? I know that we're running short on time. I think that to your question about education level, I think that we're this is an area where we really need improvement upon. I know that informatics is offered in some of the PhD programs as well as masters. I've done some guest lectures for undergraduates on technology, and it's not about gadgets per se, it's not about coding, but just understanding the world in which we live today. And I think it's incredibly important that this is brought into undergraduate curriculum, and not necessarily by retraining faculty, but actually bringing in specialists who this is what they do.
I think we have time for a last question from a committee member. Dr. Burhouse?
Yes, thank you, Sue. My name is Peter Burhouse. I'm at Montana State University, a member of the committee. And I have a question that is looking at the upstream social determinants and wanting to know, are there examples of specific technology that a nurse could use to say, improve upon the social determinants, whatever those might be in that local community. It may be housing or education or whatnot. We're exhausting our workforce by dealing downstream. And I think if we turn nurses loose in innovation, aided by perhaps technology to get at causes, root causes, it would be, I think, transformative. And so I'm excited by technology, but I really would like to see us attack the upstream. Do you have any thoughts or advice or comments on that?
Yes, there are probably about 11 or 12 solutions, which is what we call some of the technologies that are developed in any given area, directly addressing social determinants of health now, and they're being used by health systems and by health plans. They do two things, and I'm just going to try and be very quick on this, that I think are potentially really helpful. The first is, for the first time, routinely, all patients entering an emergency room, all patients being cared for in a primary care practice are getting screening tools. And so we have documentation for the first time on a population basis of how widespread the social determinants are. Things that most clinicians were scared to ask about, like ACE events, that kind in the history of children. So the sheer documentation, and it's going to be flawed, it's not going to catch everything, it will dismiss certain people that shouldn't be dismissed, but it is beginning to get a toehold to know how big the problem is and what the distribution of it is. That, I think, is very important. The second thing is they're actually documenting closing the loop. Did the patients get the services, the housing, the nutrition, whatever it is that they need, and were their clinical outcomes in their own lives improved? So as a tool, which could be good or be bad, it can allow, for the first time, to put us face to face with exactly how broad spread and deep the problems are, and how successful we're being at actually doing something about it.
Again, thank you, panelists, for your responses. We are going to take a very brief 8-minute break since we ran over just a little. We will return at 9:45, and Sophia Aragon will guide us through the next session.
Thank you.
Yeah, it was.